Content warning. This podcast episode contains discussions of a sensitive nature that may be triggering for some individuals.
5, 4, 3, 2, 1. Let's go. Diary of a Kidney Warrior podcast in partnership with Kidney Care UK, sharing faith, knowledge, hope, and love.
Hi, and welcome to Diary of a Kidney Warrior podcast. My name is Dee Moore, and I am a kidney warrior. This podcast is dedicated to encourage, educate, and inspire as we explore all aspects of kidney disease, related chronic illnesses, and health. In today's episode, we're opening a conversation that many of us need but rarely hear through a kidney lens. Menopause isn't just the change, it's a journey with stages, symptoms, and decisions. And when you live with CKD, that journey can feel twice as complicated. Today, I'm joined by Dr. Vikram Talaulikar, a leading menopause specialist and associate professor in women's health. We'll break down what really happens during this transition, clear up common myths, and talk through practical ways to manage symptoms, both lifestyle and medical. And Dr. Vikram will be back soon for a listener-led episode, so keep an ear out for how you can send in your questions. So, let's go. Hi, and welcome to Diary of a Kidney Warrior podcast. How are you doing today, Dr. Vikram?
Hi, Dee. Thank you so much for the invite. I'm doing well. Thank you for asking. I hope you're doing great too.
I'm really good. I'm really looking forward to our interview today. This topic that we're going to be talking about today is something that I really do have a genuine interest. So I am really excited about learning more. So listeners, today we're talking about menopause and CKD. Now, menopause is something that we as women, the women out there, the listeners out there, hear a lot about, but sometimes there's misinformation. Sometimes there's things that cause confusion, but as CKD patients, as kidney warriors, there's that second layer of complications and things to deal with. And so today we want to demystify those myths. We want to clear that confusion, and hopefully by the end of it, you'll have a really, really good understanding and knowledge of the subject. And I know Dr. Vikram's going to share some really golden nuggets for us today. So yes, without further ado, I'm going to start with my first question. And my first question is, and with topics like this, I like to start with a definition. So my first question is, what is menopause?
Good. So let's go to the basics here. So menopause, often also called as the change, refers to the time when, in simple terms, periods stop. So a woman who is experiencing periods throughout her life will come to a point where her periods will stop. That's a general sort of way of looking at menopause. But the menopause is actually a bigger journey. It's a transition, it's a phase that involves three components. You have perimenopause, you have menopause, and you have postmenopause. And each one as a definition. So perimenopause is the first phase when a woman will start experiencing some changes to her periods and some symptoms of changing hormones, usually at the age of about 40, 45, or close to 50. This is a change where hormones are fluctuating and the ovaries are starting to produce less and less of the estrogen, the progesterone, as well as the testosterone in the background. And that's going to cause the first changes to periods, which might be shorter menstrual cycles or longer menstrual cycles, depends from person to person. And along with that, there will be some symptoms of menopause, which we will talk about later. That perimenopause phase, where the first changes start being noticed, can last as short as maybe 6 months, 1 year, or can be as long as 5 years or 10 years, with an average being about 2 to 5 years for most women. Then comes the menopause. So this is technically defined as when a woman has stopped periods, not just changing periods, but she stopped periods at least for 1 year or 12 months. So we call it 12 months of amenorrhea, absence of periods. that confirms somebody has technically achieved menopause. So you've moved from perimenopause to menopause. And that finality for most women will happen between 45 to 55. That's the age range when 90% of women will have their menopause. And any time from that point on comes the last phase, which is the postmenopause. So from 1 year of having had the last period until end of life, whether it's 10 years, 20 years, 30 years, 40 years of a woman's life, almost more than 1/3 of the whole lifespan will be in the postmenopause, which is all that phase from that point on until the end of life. So that's the whole menopause transition journey.
So, looking at perimenopause, because you said that sometimes the periods can be longer, sometimes the periods are shorter. Now, if your periods are longer, you're not necessarily going to think, oh, this is a sign that I'm going towards menopause. You might be just like, oh my gosh, I've got a longer period, and all the feelings around that. So how do you distinguish between normal fluctuations due to stress or whatever it may be and actual perimenopause?
So it's a combination of factors. It's a very good question because often it's very difficult to differentiate what is due to stress, what is due to some other condition or some hypothalamic stress, or whether this is definitely perimenopause or menopause. And we look at a combination of factors. First of all, age. So if you're getting towards your 40s, even late 30s in some ethnicities, and I'll talk about ethnic variation in a minute. If you're getting towards 40s and you're starting to note that the length of your menstrual cycle is changing, so your periods are coming too close together every 2-3 weeks instead of, say, monthly period, or you're skipping periods and the length of the cycle is getting longer. So you're bleeding every 6 weeks, 8 weeks, 2 monthly or 3 monthly. Then that's one indication this is likely to be perimenopause. The second thing you will see is the number of days you bleed. Again, if your bleeds are getting lighter and lighter, it's likely that your hormones are going down. So it could be perimenopause. But if you bleed heavy, then that could be a problem. It could be some gynecological pathology like fibroids, or you could have endometriosis or adenomyosis. There are a number of conditions which may make you bleed heavy. So the key to look for is the duration of your cycle rather than the actual period. If it's becoming shorter or longer and your bleeds becoming lighter, that's more likely to be perimenopause. Stress will usually cause changes for a month or two, but it will usually revert back to your natural cycling pattern if it's only related to stress most of the times. While perimenopause is likely to become more and more changes to your cycles and periods as time progresses, that won't return back quickly to normal. That's again another indication you're heading towards the change rather than just a short blip with the stress.
So at what point do you speak with a doctor? Is it generally accepted that during the perimenopause stage that you just have to go through it? I mean, is there like very serious symptoms at this point generally, or is this something that you're just expected to go through without any kind of medical help? At what stage do you actually need to go to a doctor?
So it depends from person to person. As we know, menopause is physiological. It's a transition phase. And every woman has a unique journey through menopause. So when you go through perimenopause, some women will notice changes to their periods. They may have symptoms, a little bit of hot flashes or night sweats or a bit of vaginal dryness, changes to skin, for example, or a bit of mood changes may happen. But they may find that they're able to carry on without needing medical intervention. They might take time to monitor how their symptoms develop. They might be doing some lifestyle changes and simple strategies to cope with these symptoms and may want to stay away from medical intervention, which is perfectly fine as long as they feel the symptoms and the changes are not impacting their day-to-day work or day-to-day life. They can carry on. But equally important is if any of those symptoms or changes start impacting life, work, quality, then you should seek support or help immediately. So whether it's your general practitioner, whether it's a gynecologist, whether it's your kidney specialist who can signpost you to other doctors or health professionals or a nurse at your practice, if you're starting to notice these perimenopause symptoms and changes which are bringing you down, you're not able to manage them, then don't wait. It's important that you can actually go and talk to your health professional and seek help. There are many things which we will discuss later you can do to take care of those symptoms, whether it's lifestyle, non-HRT, HRT. And when you talk, you'll be able to better understand what is going on, what to expect, and what to act on medically if you need to.
Is there a test that they can do to confirm that you're in this stage?
One doesn't recommend or advise doing blood tests for hormones in this state. And the reason for that is the hormones are fluctuating. So you have few days or weeks where your hormones may be normal. You have a normal estrogen, normal FSH, LH. Just the next week, your FSH, LH will shoot high, estrogen will be very low. And the week later, there'll be again some production of hormones from ovaries. So you see that kind of a pattern in the perimenopause. So the day I catch you, I'll get one picture today. But if I do your bloods in a few days or few weeks, I'll get a different picture. So we often say you might just keep doing bloods and get nowhere because we know it's going to be normal and abnormal throughout this phase on different days. So it's best to go by how you feel and address the symptoms rather than do bloods to kind of decide what to do next.
So you've now completed the perimenopause stage and your periods have completely stopped. At this point, what are your options? What should you be looking to do in terms of managing? Because you mentioned some symptoms, but what other symptoms could you be facing when you're in the menopause stage?
Yes, so menopause affects head to toe. And in fact, people think there are about 35 symptoms which are related to the menopause transition, quite a lot. So if we start from head to toe, menopause or lack of estrogen, the lack of progesterone, the slow going down of testosterone, these hormones are plummeting and the body starts recognizing some of the effects. Now you might ask me, how many women have symptoms? From the studies we've done so far, we think about 80% of women will notice some or other symptoms. And many will have mild symptoms, some will have moderate, some will have severe debilitating symptoms. So out of the 80%, it's thought that about 1/3 of that group has severe symptoms that they have to consider some or other medical intervention. Others might monitor or do lifestyle changes and may not always need medical intervention. But it's completely down to the woman. If she feels need for some support and help, she should get it. She should not be left to herself or fight for the care that she should get. Symptoms can be headaches, can be migraines, can be brain fogging. Often when the menopause happens and the perimenopause sort of is going into menopause with very little hormone being produced, women will start having memory issues, not remembering what they did just a while back. You go to a room, you don't know why you're there. You're in a meeting and you can't remember a word easily. Many of us have these experiences, but it'll be quite obvious, and the brain fog happens again and again with the lack of estrogen. That may then have some knock-on effect on the confidence, because then you're worried about, I may forget a word, I may not know the person I'm saying hi to. From that point on, it's fatigue. It's the chronic fatigue, not being able to get up in the morning. There's no motivation. You can have joint pains or muscle aches all over the body. And that's again going to be relevant when we look at CKD. Often these symptoms overlap so much with many of the symptoms of CKD that the fatigue, the lack of motivation, the sort of no going and getting up scenario, then the aches and pains, then there'll be changes to skin. So dryness of skin, eczema, or new sensitivities can come up. The symptoms often less talked about are the mood changes. So having low mood, depressive thoughts, feeling a lot of anxiety, sometimes even palpitations associated with anxiety. These are often not talked about because of embarrassment or because of shame but we know that often these can be the only symptoms rather than the classical symptoms. Hot flushes, night sweats are the classical ones. So often people will attribute menopause to lots of hot flushes, a feeling of warmth or heat all over the face or the extremities, and then you go red. And then that can usually finish with chills or sometimes sensation of a lot of sweating. And if it happens at night, we call them as night sweats. Sleep can be disturbed. So quality of sleep goes down. Often there is waking at night and you can't go back to sleep. Or sometimes because of the sweats, you keep getting disturbed throughout the night. So sleep can be a big issue. And then finally, you have the sort of sexual or local vaginal symptoms. So low libido, low sexual desire can be one of the symptoms. Equally, there can be vaginal symptoms, vaginal dryness or bladder changes, going to the loo again and again, urinary frequency. And there can also be urinary tract infections, which is relevant again, which is quite important. So those sort of local changes can also be part of the whole scenario. And the local changes may be the only symptoms rather than the systemic symptoms for some. That's just a summary of most common symptoms we come across.
So there's a lot there that an individual can be facing, like you said, from head to toe, from the brain fog to not being able to sleep at night and all those different disruptions to life. You mentioned that women might not want the medical route, they might want a lifestyle change. So what lifestyle changes would help with those kind of symptoms?
So again, there's a wide range of lifestyle measures we often say may help with many of the symptoms if you want to keep medical interventions away. For example, first of all, it will be a healthy diet. So eating well, eating small portions, typically a Mediterranean style of eating, not having too much excess carbohydrates, excess saturated fats, the general diet advice. Many women find that eating foods like soya, tofu, which are sort of rich in phytoestrogens, which can be having very, very, very weak estrogenic activity. Pulses, cereals, legumes, they also contain phytoestrogen. So these sort of foods may sometimes help a little bit with the symptom resolution. Making sure there is good intake of calcium because of the bone aspect of menopause, and making sure your vitamin D intake is good, whether it's the supplements or whether it's exposure to sunlight, because you're going to need this vitamin D, calcium, and a little bit of protein for your bone. So those will be really the lifestyle part in terms of the diet or eating. Then it's the sleep. So you can have, very importantly, a good sleep hygiene. Most of us in the modern life struggle to do that because we have mobiles, we have TVs, we have technology all around us. And it's a temptation to look at the last message before you go to bed. And so the important bit here will be not trying to get to screens at least 30, 45 minutes before you sleep, because that will activate your brain. Try and maintain as far as a cool and a pleasant temperature so that it's pleasant for you. Maybe reading a book, setting the timing. I'm going to sleep by certain time and get up. So a rigid sleep routine so no one disturbs you. Even writing a pen and paper sort of list. If you wake up at night, keep a blank paper and a pen next to it. So if you're having too many thoughts, jot them down so it calms your brain, you go back to sleep. Some sort of sleep hygiene routine will go a long way to help. And then magnesium is thought to be a supplement which can help. This is a supplement, of course, but some women find magnesium glycinate is one of them which can help with the sleep issue. And the last bit of lifestyle will be a lot of exercise. So whatever way you can do it within the limitations of the medical conditions that you have, or as much as you can do weight-bearing exercise, doing anything that's sort of brisk walking, jogging, running, skipping, anything that takes you anti-gravity is very, very good for bones. And then, of course, it will be good for your heart because you're raising your pulse rate. So exercise as much as possible, 150 minutes a week. It also helps menopause symptoms, make you sleep better, elevates your mood. And so for many women, these sort of lifestyle changes, in addition to the standard one, no excess alcohol, no smoking, not much of caffeine, spicy food, which can trigger symptom. That's in a nutshell will be the lifestyle measures.
And what medical interventions are okay for kidney patients?
So you have non-hormonal and hormonal therapies, which can both be used for menopause symptoms, improving quality of life. But also remember that we're looking here at the bones and the heart, because one of the things that can happen with menopause is often with lack of estrogen, the bone density will start going down. And often with lack of estrogen, the bad cholesterol rises, the atherosclerosis progresses, the high blood pressure can worsen. And those sort of changes are again typical when the menopause transition happens. So when we look at the sort of non-hormonal hormonal therapies, we kind of assess the benefits risk of either. So non-hormonal therapies, there are many. So let's start with the non-pharmacological ones. For example, cognitive behavioral therapy, CBT. This is known to improve mood, anxiety, hot flushes, night sweats can be suppressed, as well as good for sleep. Because you go through some techniques, how you breathe when a hot flush happens, how do you count through it. There are menopause-specific CBTs, which have been developed and tested, especially in breast cancer patients where they couldn't take hormones. And consistently, most studies show that if you really put yourself and apply to CBT techniques, you can manage with mild to moderate symptoms of hot flashes and sweats and anxiety and mood changes. Some people follow hypnotherapy, acupuncture, or herbal remedies. Now, again, there's not a lot of evidence for acupuncture or herbal remedies. And again, we don't know the long-term safety of some of the herbs. So they're not medically recommended. So one would concentrate either on the CBT or hypnotherapy being the main sort of non-pharmacological aspects of treatment here. Medicines-wise, if someone is having lots of hot flushes, sweats, and their mood is low, antidepressants or what we call as SSRIs or SNRIs can help. These are a class of drugs which are often used as anti-anxiety or antidepressants. Fluoxetine, venlafaxine, citalopram, sertraline, there are many of these. And these can again suppress the symptoms and improve mood and help with sleep. They have got their downsides. They can cause drowsiness, dry mouth, constipation. So one has to kind of weigh the balance of benefits and the risk. And there are a few others, something called gabapentin, pregabalin, clonidine. We often don't use these medications now as much because their side effects are many. And they have sort of reasonably mild to moderate effect on hot flushes. They don't help anything else much. So really, you're looking at the SSRIs and the CBT as the two main non-hormonal treatments for menopause symptoms. I'll just mention one more, which is a new drug on the horizon, which is called NK3 receptor antagonist. This is a very new medication that was licensed in UK last year. And it blocks the hot flushes in the brain, the hypothalamus, where they are generated. So it's a brain medication that stops hot flushes and reduces about 60-70% of flushes. Now, we don't have a lot of experience or data about the use of this medication in CKD patients because it's very new and it's not been tried. But one hopes in future, one could use this additionally to the SSRIs and the sort of non-hormonal treatments we have. So then we move on to the hormone treatments. And what are the advantages of hormone treatments over the non-hormonal treatments? The big advantage of the hormone therapy or hormone replacement therapy is that it is not only going to cure your symptoms or improve your symptoms, but it does benefit the bone and the heart as long as you start it early enough. So the advantage with the HRT is it's going to take care of all the symptoms we discussed, but it will build fresh bone. It's osteoblastic. It's very good for bone. So any sort of loss of bone density can be prevented during menopause. Equally, estrogen is very good for heart, for cholesterol. So it is cardioprotective. So it reduces worsening of cardiovascular disease, or in a way, it will prevent cardiovascular disease from happening if you start HRT early during the menopause transition. And the HRT can be in many forms. So if somebody is just having vaginal symptoms, they don't necessarily need to take the HRT for the whole body. They can just take vaginal estrogen as pessaries or rings or creams, and it's very, very effective against vaginal dryness, pain, or urinary tract infection prevention. Very effective, no risk of thrombosis, blood clotting, no risk of breast cancer. Very, very simple to use and often underused. Health professionals don't use vaginal estrogen enough. That's one thing we really need to change in future. But equally, you can have the whole body HRT if you're having hot flushes, brain fog, night sweats, sleep issues, mood changes. You can have HRT right from the time you're in perimenopause until postmenopause. Even though you're having your periods and they're irregular in perimenopause, don't worry, you can still have HRT and you can start at that point if the symptoms are bothering and causing problems for you. And you can carry on as long as needed. So you can take estrogen, progesterone as part of HRT, sometimes additional testosterone. You can carry on for 5, 10, 15 years or longer, depending on how long you need the benefits to continue, and as long as the benefits outweigh any risks for you. So there is no arbitrary limit to HRT. You can carry on as long as benefits outweigh risks.
You mentioned that in HRT, there's estrogen and progesterone. Well, the contraceptive pill has estrogen and progesterone in it. So is it the same kind of thing as the contraceptive pill, or is it something completely different?
Very good question. So again, this is different because the contraceptive pill is quite strong hormones. It's a synthetic form of estrogen called ethinyl estradiol that is often combined with a synthetic form of progesterone. And the dose is often supraphysiological, more than physiology, because the pill has to suppress body's own hormones to prevent ovulation and prevent pregnancy. That's the main reason it's given for contraception. It has higher risks of blood clotting, for example, because the dose and the type of hormone is quite different than body's own. But the HRT is not like that. HRT is much milder. It is physiological. It's trying to simply replace the hormones to the same level that you had before you went through menopause. We now use what we call as body identical or natural estrogen. And we use a progesterone or a dydrogesterone, which are again more biosimilar, body identical forms of progesterone when we can. Because that's the modern body identical HRT, which is far more safer, doesn't have the same risk of blood clotting, and again has minimal impact on any risk for breast cancer. Those are the modern forms of HRT that are recommended. And so they are very much different from the pill.
How do you know what someone's normal level of hormones are when they reach this stage? Because like you said, there's so much fluctuation within the perimenopause stage, and then obviously we reach menopause and the periods stop completely. So how do you actually know what's normal for each individual?
It's the symptoms. So again, I think we've traditionally grown up thinking blood tests diagnose something and we treat it. That's true when it's pathology. So if there is an infection, if there is a problem, if there is damage to an organ, the blood test will show it. And based on how much is the damage assessed by blood tests or a scan, you treat it. That's the traditional medical model. Remember here, this is physiology. This is not pathology. And so therefore, every woman will have a unique threshold at which point she gets the symptoms and how severe the symptoms are. So testing during perimenopause doesn't help because it's all over the place. So if the woman is getting symptoms which are troubling her, you start HRT or non-HRT treatments. During menopause, there is no need to test the blood because we know the ovaries are no longer producing any estrogen, which is required for symptoms, or the progesterone. So even if you test somebody's blood, you know what the result will be. Low estrogen, low progesterone. So what's the point of testing? That again is the symptom. So if somebody is having symptoms which they cannot cope, they are bringing them down, they cannot carry on with the fatigue, with the symptoms they are having, that's when the role of HRT or non-HRT treatment comes. So testing for bloods and the levels of hormones has almost very, very little role in menopause treatments. It's usually all based on symptoms and quality of life. And some women might say, okay, how do I know HRT will benefit me? How do I know this is significant enough? And we often say, okay, if it's starting to trouble you, do a trial of hormone replacement therapy. Do it for 6 months or 3 months, and you will get the answer. Because if your body is really having the trouble from symptoms due to lack of hormones, the moment you take HRT, you will notice the difference. While if you don't notice the difference, HRT is not doing much for you, or any other form of intervention is not changing your symptoms, then you know this is probably not going to be only menopause. It could be work, it could be life, it could be stress. That's when you will not continue with the intervention.
Rewinding slightly, you mentioned earlier that there's variations in terms of different ethnic groups. So what are these variations?
So it's known that menopause happens at the age of somewhere between 45 to 55 for 90% of women. And in the Western world, let's say Northern America or Europe, it's the average age is about 50, 51. But if you look at Afro-Caribbean women, it's usually 9 months to about 18 months earlier, almost 1 year to 1.5 years earlier. And if you look at, say, South Asian women, it's 5 years earlier. The average age is 46 and a half. Now, that's a lot of difference between two populations, between the Caucasian group and the Asian group. And if you look at the symptoms, again, you find that Afro-Caribbean women predominantly have the severest hot flushes, night sweats, and sort of classical symptoms, while you often find that other symptoms like joint pains or vulvovaginal symptoms or muscle aches, fatigue are much more common in Asian population. Mood changes are usually more common in certain European groups. So there does seem to be quite a bit of ethnic variation in terms of when it happens and what are the main symptoms that are sort of emerging. A lot of more studies required. This has been a topic that's been neglected over the years and years of research. So hopefully, as we now talk more about menopause, we are researching more in relation to CKD. Again, very little data. As we research more and collect more data now, hopefully in 5 or 10 years, we'll have much more knowledge about this.
So how does CKD affect menopause?
Overall, if you look at the age of onset of menopause, there is a relation with CKD. So women who have CKD, especially significant CKD, tend to have a higher risk of early menopause. It's estimated to be about 2.5 times the risk. So early menopause is when it happens below the age of 45, because we know 45 to 55 is the general age range. If it happens between 40 to 45, we call it early menopause. And if it happens below the age of 40, we call it premature menopause, also technically called premature ovarian insufficiency. So women with CKD do have a risk of early menopause or even POI, premature menopause. And that's come out from studies which have controlled for other things, because often the question was, is the early menopause or premature menopause happening because of other comorbidities? Is it because of heart problems, high blood pressure? Is it because of ethnicity? So when people did studies and they matched for all these characteristics and the only variable was the age of onset of menopause, they realized that yes, it looks like it's the CKD where women may be at higher risk of having early menopause. And the vice versa is equally true. So if a woman goes through early menopause below 45, she seems to have a higher risk of having CKD later on. And the basis behind this is because estrogen, progesterone are involved in kidney function heavily. There are loads and loads of estrogen, progesterone receptors which almost govern every function in the kidney, from the glomerulus to how the fluids are drained and what happens with the electrolytes and the mesangium. Almost everywhere there is some function being affected by hormones. So it's thought that if you lose estrogen early in life, it does have some bearing on your cardiovascular system, on your heart, on your blood vessel, on your blood pressure, eventually on your kidneys. And you have that slightly higher risk where you may be diagnosed with CKD more than if you don't have early menopause.
I had no idea that those hormones in particular had any impact on the kidneys at all. I mean,
They do.
it,
They
it,
do.
it really is amazing, like how much the kidneys do. The fact
Yeah.
that those hormones that you associate really with your ovaries and your womb actually have an impact on your kidneys. That's fascinating.
It is.
So, how does CKD impact the way that you treat a patient with menopause symptoms?
So now that we know that both have bearing on each other, CKD can affect menopause age, early menopause, and early menopause or menopausal women may have CKD. So there's a bit of a crossover here. For example, symptoms may overlap: the fatigue, the brain fog, the lack of energy, the joint pains, anxiety, sleep issues, which come as a sort of second effect of these, the lack of sleep, may all be sort of overlapping. Equally, the changes which are happening to bones. So we know with CKD, if you've had transplant, there could be steroids, there could be immune medications. All those will have a bearing on the osteoporosis risk or bone loss. Similarly, menopause transition is going to increase the bone loss. Then often there is cardiovascular disease burden with CKD. So again, high blood pressure, atherosclerosis, increased cholesterol. Menopause is going to cause it. CKD is going to have an influence on it. So you can see there's so much overlap between the two. And you're constantly thinking about these. If the woman is going through menopause, she's starting to notice symptoms. That's the first bit. Of course, she can have all the options. She can work through lifestyle, which we talked about. She can work through the non-hormonal options, whether it's CBT, SSRI, other techniques. She can have HRT, hormone replacement therapy, can be very well used very effectively in women with CKD. Often the dose has to be the least effective dose. We don't often go and give very high doses so that it's the lowest effective dose that treats the symptoms. We often give estrogen in a transdermal way through the skin and not as an oral tablet because that eliminates extra risk of blood clotting. So it's safe. We try to combine, as we discuss, body identical hormones, which have the least risk for the breast. And so you will try to use the hormones in such a way that it kind of negates or tries to minimize any blood clotting, any cardiovascular, or any risks related to breast. Similarly, you can use other non-hormonal medications, but make sure that you're looking for any drug interactions because with CKD, there may be many medications that the woman may be receiving. So we're going to check that none of these cross-react. So we can choose the ones that don't react with the medications that the woman is already taking and the side effects don't add up. So that is specific to CKD. Women can safely have hormones. They can improve their quality of life. It will also add to their bone health. It will help their cardiovascular health. And all those benefits we're going to kind of balance against a small risk that comes through with the breast cancer, but we try to minimize it. It's anyway less than 5 to 10 in 1,000. And the benefits for many, many women far outweighs any very small increased risk of breast cancer for them.
It's very difficult, isn't it? Speaking to someone with more than one chronic illness, you don't know where one starts and the other one ends. Is it because of this or is it because of that? So it must be a very difficult thing to know which one is which. So how do you actually work out that when you've got two different conditions going on at the same time?
It's a very good question. And sometimes this kind of puts us into a bit of a difficult position as healthcare professionals, because you can imagine primary care physician, GPs, or hospital doctors, or nurses who are dealing with women who go through both menopause and the CKD issues. Sometimes there is no way to completely distinguish the set of symptoms that the woman is having. But you kind of work it out based on when did it start? Were these symptoms there before? Have you only noticed them now towards as you've got to your 40s? Are there any typical menopausal symptoms, flushy sweats, which are unlikely to be CKD? Or are there more of generalized symptoms which were there for a long time and not necessarily with the changes in periods, more likely to be CKD? At the end of the day, it's the clinical judgment. And often when you see a lot of women presenting with these two conditions over a period of time, you get yourself trained, you get yourself better at recognizing, this must be definitely menopause. Why don't we try an intervention, a lifestyle, or a non-HRT, or a hormone replacement therapy? And you often find if the symptoms improve, yes, you got it right. Sometimes you might find in the occasional person that the HRT doesn't make a difference or the drug doesn't make a difference. And you might say, let's take a break. It looks like this is background medical issues and not hormones. And we can continue monitoring and we may have to revisit the intervention. But that's how you work out sometimes when you can't clearly distinguish between the two processes. The key here is to address the symptom and not let the woman suffer. So what sometimes is difficult to understand or is painful is women may come up with symptoms and they're dismissed thinking, this must be your medical issue. This must be down to you've had this, you've had that, there's a new medication, there is stress in life. Let's forget it, let's carry on. That's when sometimes things go wrong, is because somebody has not thought this could be hormones, this could be menopause. Why don't we approach and see whether HRT or some other approach helps? That's missing many a times.
So in terms of a woman with CKD going through the menopause, would they need more frequent observation than the general public, or is it the same?
No, I don't particularly feel they will need any more intervention as long as they have had the access to have a discussion. That's the key. As long as they discuss, could their symptoms be menopause? What's likely stage at they are in the menopause transition? Could lifestyle be changed to help some of them? Could non-HRT option be used? Or are the symptoms definitely getting worse and bothering or troubling them in their life and work? So could HRT be an option? Could they have it and see how it benefits them? And if you give that option, then I think the management could be even like anybody else having menopause HRT or non-HRT medication. Doesn't have to be more intensive or doesn't have to be specifically different. What's important is that first access and then a follow-up to make sure that things are working or not working. For most women, we recommend one review a year. So once you're stable, once your menopause symptoms are getting better, then you have one review with your GP or with your hospital doctor or nurse once a year to keep an eye that your benefits outweigh the risk. And then you continue with those reviews as long as your intervention will continue.
So you mentioned that it could be your GP or someone else. So it isn't necessarily a consultant that has to be monitoring somebody with CKD going through the menopause.
No, in fact, a lot of GPs are now getting trained in menopause. There are many specialist women's health GPs, usually one or two in every practice, who've completed training with, say, British Medical Society, Menopause Society, or you have FSRH, Faculty of Sexual Reproductive Health. There are other menopause education bodies. And so people are getting trained to the extent that they can handle complex menopause situations. Yes, of course, some GPs may need advice in very complex patients with lots of comorbidities. And then they may have to refer a patient to a specialist menopause clinic in a secondary or a tertiary care hospital. And we will always be there. We will always be there in the background for helping by email, by phone, or by referral and seeing in the clinic. But of course, remember that many patients can easily be advised even by their primary care physician because it's so much awareness and better training now than 5 or 10 years ago.
So rewinding slightly, because like I said before, this is something I'm really, really interested in. So I want to get as much knowledge as possible. Hey, listeners, this is for you. You mentioned about HRT, but what are the different types of HRT that are available?
So HRT is hormone replacement therapy, and basically it's combining estrogen and progesterone. And for some women, we also add the testosterone. Now, estrogen is used as body identical estrogen. That's the most common way of giving it. And it's called 17-beta estradiol. That's available as patches, which you can apply on the skin, as gels, which you can rub into the skin, as sprays, which you can spray on your arm, It's also available in the form of implants, which can be inserted under the skin, and of course, oral tablets. In the modern world, if somebody has a medical condition like CKD, or if somebody is already about the age of 55, 60, one often avoids using a tablet of estrogen because the oral estrogen causes changes in liver and blood clotting risk, which is small, but it's there. While if you take estrogen through patch gel or spray, it does not increase your baseline risk of blood clotting, which is already there. If you look at the progesterone, there are different forms of progestrogens, which are synthetic, and you also have a natural progesterone or a body similar dihydrogesterone. So, as we discussed before, it's these two, the natural progesterone orally or vaginally, or the dihydrogesterone, which is oral. They are the preferred progestrogens because they have the least risk for breast tissue or breast cancer. There are, though, other forms, for example, oral Provera, oral norethistérone, or a coil form, Mirena coil, which is a hormone coil which can also give you progestogen. These tend to be used mainly if there are problems with the natural progesterone, like you bleed a lot on HRT or you have side effects, then sometimes you use the coil or the other forms of progestogen. For women who've had a hysterectomy, those whose womb has been removed, say for fibroids or bleeding or endometriosis or any other condition, they only need estrogen. The women who have a womb need the progestogen because it protects the lining of the womb from the effect of unopposed estrogen. So estrogen increases the womb lining thickness, progestogen keeps it thin and prevents any womb lining cancer. That's why if a woman has a uterus, you need both hormones in enough dose. But if the woman has had a hysterectomy, then she'll usually only need estrogen, unless there are specific situations where we also recommend a progestogen. Testosterone at the moment is mainly used if somebody is on HRT and are still feeling very low libido, low energy. Sometimes testosterone addition can help, and it's used as a gel or a cream. And it's available again on the NHS as body identical testosterone, and we use it sparingly in a very, very tiny dose using a sachet or a pump of a gel. So that is in a nutshell the systemic HRT. While the local HRT we talked about for vaginal symptoms, you only need vaginal estrogen cream or tiny pessary tablets, or you have a ring. That should more than enough take care of any vaginal symptoms, and it's very, very risk-free.
So modern technology really has improved the options that women have in terms of dealing with these symptoms and also in reducing the risk that's associated with it. So it warms my heart to hear that. So today, Dr. Vikram, we have shared about menopause, the stages of menopause, perimenopause, menopause, and postmenopause. We've talked about the different treatment options, HRT options, non-medical options that are out there. We've talked about the age onset of menopause, generally when it happens. We've talked about the differences that can happen between different ethnicities. We've talked about lots of different things. We've covered a wide range of information today. But you see, listeners, we've got an extra special treat for you. Dr. Vikram is going to come back